Good morning, everyone, and welcome. I'm Cheryl DeMars, the President and CEO of the Alliance, and welcome to our Fall Symposium and 31st Annual Meeting. We're going to start this morning with an educational component focused on payment reform, and then flip into our business meeting, where we'll share some highlights from the last year. But first, a few housekeeping items. There are 259 of us here today, so I want to first say welcome to you all again. And while you're all in mute mode, we want to hear from you. So please use the chat feature to ask questions along the way. We will break into the presentations to respond to any clarifying questions, but save comments and discussion for the Q&A at the end of each section. I also want to thank our sponsors, Delta Dental, National Cooperative RX, and Group Health Cooperative. We so appreciate your support and partnership, and you can find more information about our sponsors in the webinar section of GoToMeeting under the handouts. There will also be the presentations from today and other materials. Before we get started, I want to plug our next event, which is Thursday, October 14th from 9 to 10:45. This will be a health policy related webinar featuring John Barlament, who I know many of you know. John will be sharing updates on the latest information and regulations, policy changes that really will impact the market and our health benefit plans. So we hope that you'll tune in for that. Our focus today is on healthcare payment reform, because how it is that we pay for healthcare impacts how healthcare gets delivered. And right now, the prevailing way that healthcare is paid for in this country is filled with unintended consequences that really work contrary to the goals that we have of having high quality, affordable health care. And we're joined today by Suzanne Delbanco, who's going to tell us more about payment and delivery and why transformation is so badly needed. The good news for members of the Alliance is that because you're part of our cooperative and because we negotiate contracts on your behalf, we're actually in a position to do something about this. And so the second part of our program will feature Kyle Monroe, who will be sharing what progress we're making in the area of payment reform. Suzanne is the Executive Director of Catalyst for Payment Reform, or CPR as it's known. And CPR is an independent nonprofit corporation working to catalyze employers, public purchasers, and others to implement strategies leading to higher value healthcare while improving the functioning of the healthcare marketplace. Suzanne was previously the founding CEO of the Leapfrog Group, and she holds a Ph.D. from the Goldman School of Public Policy. Suzanne is also a longtime friend and colleague and a tireless advocate for better, more affordable healthcare. Suzanne, thank you so much for joining us today, and we look forward to your comments.
Thank you so much, Cheryl. And it's been a highlight of my career to have been able to interact with and collaborate with the Alliance over the last 21 years now. So I really appreciate the opportunity to speak with all of you today and to tell you about my daily work, which is working on the need for more payment reform. So what I want to share with you today, more than anything, is that you all have a role to play. And like Cheryl said, it's wonderful that you have the vehicle of the Alliance to enable you to enact certain changes that are sorely needed. So this is all about how you are in the driver's seat, and choosing the road to better, more affordable healthcare is within your grasp, but it's going to take a fair amount of work. So Cheryl already gave a beginning introduction to Catalyst for Payment Reform. I just wanted to share with you who our membership is. We've got household name, Fortune 500 companies, but we also work with a growing number of state, Medicaid, employee and retiree agencies. We've got a couple of multi-employer union trust funds, a university, a nonprofit, healthcare marketplace covered California, et cetera. So we have a diverse group of members, but what they really have in common is the recognition that how they buy healthcare needs to change, and that working together, they're likely to have more of an impact on making the healthcare system more responsive to the needs of those who use and pay for healthcare than they are by working alone. And you already, again, through the Alliance have that vehicle. Our goals are really threefold. Every year, we're hoping that there will be a meaningful increase in the portion of payments that are flowing through methods that are proven to improve the quality and affordability of care. That means how we pay doctors and hospitals. We hope that we will continually evolve that so that providers of care feel the incentives that they need to be able to change how they're delivering care in a way that works better for all of us who are, again, using and paying for it. Another goal that Catalyst for Payment Reform has, and another of many reasons why I'm happy to be speaking with you today, is that we want to make sure as many as possible of healthcare purchasers are educated and activated on the use of high-value healthcare purchasing strategies so that we can really support the demand side of the equation to put the right kinds of pressure and send the right signals to the healthcare delivery system. And knowing that market forces can only go so far sometimes, we also work for greater visibility and more effective policies that make the healthcare marketplace more functional. So we know there needs to be an eye on making sure there's enough competition, especially among healthcare providers. And we want to make sure that those healthcare providers feel a need for making healthcare more affordable. And that all takes a lot of work, whether through market forces or through policy intervention. So I'll talk about both today. And the way Catalyst for Payment Reform goes about trying to deliver on the shared agenda that we create with our members each year. And in fact, just yesterday, we had our annual meeting of our members at our strategy session. We do it through education, through providing plug and play purchasing tools, through helping our members create a shared agenda and articulate that to the insurance carriers and others. And we also conduct research and analysis. So we have, for example, for 10 years been tracking how much payment reform there is and what types of payment reform there are. And we have also analyzed things like state laws on price transparency and whether or not states are ensuring that citizens have access to price information when it comes to healthcare. So we work in a variety of ways, but again, we're a 501c3 nonprofit with an educational and charitable mission. And just so all of you know, all of the resources that are on our website are available to purchasers for free. If you go to catalyze.org and you create a login for yourself, you can get all the education you've ever wanted, everything from online courses to shorter webinars to action briefs. And there are also all the plug and play tools there that you don't necessarily need because of your work with the Alliance, but there may be some there that could be helpful to you. So let me start. You're going to think I'm totally jaded and cynical, after I talk for the next few minutes, but I want to really motivate you and help you understand why you really do need to put your hands on the steering wheel. If it's not already obvious to you, the healthcare marketplace just isn't working. We have a growing imbalance of power between the supply side of healthcare services and the buy side. I will talk more about this, but as healthcare providers have consolidated for a variety of reasons, there's less and less competition among them, which makes it possible for them to have more market power and charge higher prices. And other than a few very select examples across the country, like the Alliance, there are very few places where purchasers are organized together and enabled to really act as a force when it comes to the negotiations that need to take place around how we pay, how much we pay, et cetera. And when it comes to the end user in the healthcare system, the employee, the patient, shopping is much too complex for most end users. It's not like this picture on the right of this beautiful farmer's market where people can see the product in front of you, they can ask the price, they can feel if the tomato's ripe and purchase it. It's really all very obscure and hard to understand and analyze for the end user. And until very recently, they haven't even been enabled to ask for the price or to get that information before they receive care. And prices in the healthcare system continue to outpace inflation. And as you probably all know from your businesses, the cost of healthcare has been eating into wages for years now. And to a place where healthcare takes up much too high a proportion of household income, and it really impairs people's ability to realize their dreams. And if at the worst or at the best, and at the worst, to be able to afford their housing or food. So, it would be one thing if, as prices rose, the quality of care got better. But as we've researched year after year, there's still very little to no correlation between price and quality. So as prices rise, it doesn't mean that quality is getting better, and a more expensive provider isn't guaranteed to be better quality. In fact, it's equal odds that they'll be better, worse, or the same as the next provider. Over the last 20 years, purchasers have worked hard to lay new foundations, and that's where my partnership with the Alliance has come into play. First through the Leapfrog Group, where we pushed for standard measures of healthcare performance and public reporting on those measures. And more recently through Catalyst for Payment Reform, where we've been working, now that we have some of that performance information available, to tie payment to that performance and to use payment as a way to stimulate improvements in the quality and affordability of care. And we have succeeded as a catalyst. When we got started, there was virtually no payment tied to quality, and now about 60% of it is. But don't get too excited. I'll share with you how we've come a long way, but not far enough. In addition, in our very first year of declaring a shared agenda at Catalyst for Payment Reform in 2011, we made price transparency a very high priority because we had a couple members, Safeway, which is a big grocery store chain, and CalPERS, which is California's employee and retiree purchasing fund. They both wanted to try a new benefit design called reference pricing, where their plan members had a reference price to consider when it came to seeking certain shoppable services like a hip replacement or a screening colonoscopy. And if they chose to go to a more expensive provider above the reference price, they would have to pay the difference out of pocket. Now, this is an innovative benefit design, and it has been shown to work pretty effectively, but you can't implement it if there is no price information for your plan members to look at. So that was what really prompted us to help found the price transparency movement, which as of today is embedded in federal law that started with the Trump administration and has been continued with the Biden administration. So purchasers have laid important foundations. And without these foundations, we wouldn't be able to advance in the ways that I'm going to suggest we need to today. So we should pat ourselves on the back for a moment and realize we've worked hard over the last 20 years, but there's a lot more to do. Prices in that period of time have continued to rise. And what's really astounding is that higher prices account for about 75% of what's driving healthcare cost growth today. So it's not, the typical thing you would assume at a cocktail party. Someone's chatting, why are healthcare prices so high? You might say, oh, it's those new drugs, or it's the aging population, or the burden of chronic disease. All these things do contribute, but nothing like the contribution that prices make to how much more we've had to continue to spend on healthcare. And as you can see, the quantity of services, which is usually the other variable on how much you spend, has contributed, but not very much. So we really have to think about the need for competition and possibly the need for policy intervention, or all the neat benefit designs and payment reforms we come up with will be dwarfed by what here looks to me like a tidal wave. So, I shared with you that we have made some progress on payment reform. When CPR got started in the summer of 2010, we did a sort of unofficial informal poll of 3 of the biggest national health insurance carriers. And we asked them, out of all the money they're spending, what proportion is tied to quality or performance in some way. And these are payments they're making to doctors, hospitals, for other services. And they said at that time, the answers range from 1% to 3%. As I shared, we're now, with our measurements, at about 60% of of all dollars paid to the healthcare delivery system have some kind of quality incentive. But over that period, we looked for some metrics that could give us a sense if on the sort of macro level, we were also seeing improvements in affordability and quality as a result. And this is actually part of a look back scorecard we did on payment reform that is available on our website. I've just pulled out a few metrics for you to see. And this one is a really important one. It's, how many Americans had unmet care needs due to the cost of them. And in other words, how many adults with commercial coverage went without care because they couldn't afford it. And you would hope over time, with all the payment reform that we are helping implement, that it would have gotten better, but in fact, it's gone the wrong direction. Whereas in 2013, it was 7.5%. In 2017, it had got up to almost 10%. And forgive the sort of spotty data here. We're not showing for every year because there are only certain years for which there were adequate samples to show the results. And quality has also not improved according to key indicators that the healthcare system's gotten quite used to and has been reporting on for 20 years. So let's just look at diabetes, a very common chronic condition. In terms of the people who are getting their blood sugar tested every 3 months to do a look back and see how they've controlled it, the testing has basically remained the same. We've moved from 89% to 90% over the time period we've been measuring payment reform. In terms of blood sugar under control, it's actually gotten worse. It's gotten worse. HbA1c showing poor control of blood sugars has taken up a higher portion of the population over the measurement period, from 31% to 36%. And when it comes to cesarean sections, a procedure that we know is performed far too often, well above when guidelines suggest it should be, we have seen it stay virtually the same and in fact rise slightly. So again, we were looking at the period of time from 2012 when we started measuring how much payment reform there was to the current day, and used the years for which the data were substantial enough that we could report them, and found that our key quality indicators, among others, were not showing better performance. And like I said, healthcare wasn't getting more affordable. So at a macro level, even though we've seen some individual programs work, and I'll talk about those, we need to do more. We need to make the incentives stronger. We need to make them more prevalent if we want to see some serious change. Now, as purchasers, it may feel like payment reform is not in your control. And I think that's why Cheryl mentioned at the beginning that this is where the Alliance comes in, and Kyle will share their plans for what they're going to do. But benefit designs are under your control. And what we're seeing is a lot of very effective new benefit designs, but not as many purchasers taking advantage of them as could be. We are seeing, for example, just 22% of employers reduce out-of-pocket costs for high-value services to remove financial barriers, and 10% increasing costs for services that are overused. This is otherwise known as value-based insurance design, and it works. It really does shift what services people seek and helps people who need certain services, who are not seeking them, afford them. And on the other hand, discourages people from getting services that they are really shown to have very little clinical value. But these are not being used very often. And when it comes to provider network design, sort of which providers are in network, which providers are out of network, not enough of them are discerning and telling healthcare providers that if you don't, meet certain standards of quality, you will not be included in the network. And that's an incredibly powerful incentive that does not require payment reform, and just basically says if you don't live up to certain standards, you will lose business because it will be out of network for a patient population that would have to pay more out of pocket to see you. So these kinds of high value benefit designs can really encourage consumers to seek care from providers who are doing a good job of, sort of being at the right intersection of high quality and lower costs. Right now, according to the latest survey from the Willis Towers Watson, 18% of employers offer a high performance or narrow network, but that means, a whole 82% are not. And as long as we treat all providers the same and pay them all the same, they're going to do whatever they can within their power to make as much money as possible and do as little as they need to really re-engineer the way they're providing care. And let me say, I am a doctor's daughter. It's not that I believe that an individual healthcare professionals go into healthcare without the desire to make people's lives better. I know they do. But it's become a very big business and a very lucrative business. And sometimes I think many of us in healthcare forget that patients are at the center of this. And it's really become, unconscionable the way that some large provider systems are behaving, where it seems like the patient is the last thing that they're thinking about. And many purchasers have delegated too much to their third-party administrators or carriers. Now, I'm not saying this is the case in the Alliance. I haven't studied what each of you has done. I'm speaking nationally. And many TPAs and carriers who have provider networks are conflicted because they want to keep certain providers in network, so they don't want to upset them. But on the other hand, they have employer customers to satisfy. And I think sometimes they're conflicted about who is their customer. And the TPAs or carriers do not necessarily share the purchaser's priorities. They may also have restrictions built into their contracts with providers that do not allow them to offer offer employers and other purchasers high value strategies like the benefit designs or the network designs I was just describing. There are contract clauses that are fairly prevalent that we call anti-tiering and anti-steering clauses, as well as anti-transparency clauses that keep providers from sharing price or quality information, or the health plan sharing that on behalf of the employer with their plan members. So these contract restrictions are more common than we think, and they really get in the way of progress. There's also been, of course, a lot of consolidation among third-party administrators and carriers nationally and regionally, and this has reduced competition and thus the need to innovate to keep customers. So I think, how you manage your TPA is really critical. What kind of TPA they are, what they're willing to do on your behalf, all of that is really important to analyze in terms of what you're able to do in terms of your interaction with the delivery system itself. And in some markets, there may be strong opportunities for purchasers to have a direct relationship with healthcare providers and find that they can get into deeper discussions about the quality of care, access, affordability, than they can when they're going through a third-party administrator who may have their own contracts. So just to share a little bit of data, I keep talking about how providers have amassed market power. Market power can come through two sources. One is just market share, and that is happens through hospital consolidation or the competition disappearing for a variety of reasons. The other way that providers acquire market power is through reputation. So sometimes a well-known academic medical center will be able to charge very high prices just because of their reputation. So there's two ways that market power arises. But this is a chart just showing nationally how many hospital consolidations there have been year over year. And I wish I had data for 2019 and 2020. I looked for it, I couldn't find it. But we're pretty certain as a result of COVID, some providers just couldn't make it through that period when utilization really dropped. with everyone's stay-at-home orders. And so we're expecting to see consolidation to have risen during 2020 and the early part of 2021. So stand by for an updated chart that will most likely show that. The other thing that's been happening is it's not just hospital mergers or health systems acquiring hospitals. It's also the fact that nearly 70% now of physicians across the country are employed by hospitals or corporate entities by the end of 2020. So it means only 30% of physicians are still freestanding or independent from big systems or big medical groups that might have their own incentives for where a provider refers people, how they practice, etc. So, you know, the dwindling amount of competition among health professionals as well as hospitals poses challenges for us. Now, in Nirvana, this would all mean that we'd have, you know, beautifully integrated delivery systems where big is better because we would have better coordination, better IT systems, better electronic health records, all kinds of things, because a big system would have more infrastructure and capital to afford that sophistication. As we've looked at the data over the years, unfortunately, consolidation does not lead to better quality. There have been virtually no studies showing that. Instead, we just see prices rise. So it's not great news. We also, and I hope nobody's too down, but we also haven't gotten payment reform quite right yet. I mean, as I shared with you, we're not seeing, after 10 years of a lot of activity, some of the key indicators of quality and affordability improve. But there's still so much more to try. You know, there's a variety of ways we can pay for healthcare, and it kind of ranges from, on the left side of this chart, paying a la carte. You know, you go to a restaurant and you order each part of the menu separately, and each has its own price tag, to really paying for everything in one payment, let's say per person, per month, or per year. And then there's lots in between, like bundled payment, where there's a package price for an episode of care, like a hip replacement. So we have many different ways of paying. And I don't think we're going to ever come to a conclusion that there's one right way, or have one, you know, one size fits all payment method across the country. With fee for service, the advantage of it is that it encourages more delivery of care. So there are some cases where that's helpful, like with mental health services. We know we have a shortage of mental health providers. We want as many of those providers thinking, hey, I guess I'll keep seeing patients because I make more money every time I see one. On the other hand, for certain low value services that are very expensive, we don't want there to be an incentive for providers to deliver those. And so they may fit better in a bundle or in a global payment. All of these methods can be improved if they have components added to them that really create incentives for quality and affordability and efficiency. They can each perform better than they have ever performed yet today. So there's a lot of work to be done to think about how to do it. Predominantly in this country, up until about 10 years ago, fee for service on its own was the method of payment. In a few unusual places like California, where I live, or Massachusetts or Minnesota, we saw more capitation or global payment happening, but very little bundled payment or anything in between. Fee for service is still very prevalent. It's behind about 95% or 97% of all payments that are still made today. Most of the payment reform that we've seen has had carrots added to it, where there's more than a provider can earn if they meet certain quality standards, or in some cases, more that they can earn if they beat a budget that was set for them and they can share in the savings. But still, across the board, we have a lot more to do. Most payments are still in what the federal government calls Category 1, which is fee for service with no link to quality and value. Only 44% of payments nationally, if you include Medicare and Medicaid, are tied to quality. So we have a lot more work to do. And this table that I'm showing you comes from research that we do on behalf of the federal government for an effort called the Healthcare Payment Learning and Action Network. And there's more to dive into in these data if you're interested. I just want to say that, how we pay providers changes their behavior. If we want providers to change how they deliver care, we can't just keep paying the same way and expect change. Professionalism goes a long way, but not enough, as we've seen. So, when we pay a la carte for each service, we get providers to deliver more services and often more expensive services. If we want better outcomes at lower costs, we need to pay accordingly. We need to create the right set of incentives for that to happen. So let me give you some good news. There are some examples of how paying differently can improve value. A study just came out in Health Affairs, which is a widely read health policy journal, that was an evaluation done by the Rand Corporation of an employer-provider direct payment program that was using bundled payment or a package price for an episode of care, and it found that it did save money. There's a private company called Carum Health that works on behalf of employers to bundle services into episodes, and the providers bill them as a team. They pay them right away after they deliver the service, which is very attractive to providers. And the payment includes accountability to improve outcomes. So Rand studied 8 employers' experiences in working with Carum Health, and it's essentially, think of it like a carve out. So the episodes that the employers work on with Carum Health are carved out of their regular plan with their TPA. And in this independent study, episode prices for spinal fusion, joint replacement, and weight loss surgery declined by an average of over $4,000, which was about an 11% reduction. And the patient cost sharing payments decreased by about $500 per episode, which is obviously very significant for an individual consumer. And I think the best news on the quality side is that fewer readmissions happen, about 80% less than the national average. So there are examples of where paying differently, and in this case, paying more quickly, can motivate providers to improve the processes they use to deliver care. Another example, the Pacific Business Group on Health, which now has a different name, but it was called the Pacific Business Group on Health when this happened, experimented with what's called blended payment, hence the picture of the blender on the side. They paid the same amount for births delivered vaginally or through C-section. And this reduced C-sections by about 20% and saved each employer about $5,000 for each one that they averted, because C-sections tend to be about 50% more costly than a vaginal delivery, and frankly can pose health risks for both the mother and the baby. And the Pennsylvania Employees Benefit Trust Fund did an early experiment for joint replacements, paying bundles, and they found that it didn't reduce spending in the inpatient setting, but it did significantly reduce spending in the outpatient setting. And I think that's because there was more included in the inpatient setting where the price remained about the same, and less of a need for extensive rehab and things like that, because the providers had an incentive to all work together to reduce their spending so that they could retain some of those savings. In the federal government, which has experimented more than anybody with payment reform, one of their longest standing programs, the Medicare Shared Savings Program, has shown over time that there are more and more savings when providers come together to serve as an accountable care organization, being responsible for a whole population with a set budget and quality metrics they have to meet. They do score better on measures of quality. And this includes in areas like making sure patients get their preventive services and fewer hospital admissions and better experience of care. Those accountable care organizations that were also willing to take on financial risk if they overspent, they would have to eat some of those costs. They had even greater reductions in spending than the systems of care that only stood to gain if they beat the budget. So those are some examples of where there are positive results, and we need to do more of those things. So how much can you fix? Some of this can feel a little bit out of your control, but you can adopt benefit designs that influence where your patients, where your plan members seek care, and what services they seek. You can be insistent on effective benefit designs with providers. You can use the voice of the Alliance to pass on this message. You could also meet directly with the providers where your population seeks the most care and say that you want them to do better. You also probably need to be willing to eliminate low value providers. To the degree you can identify those, why continue to send your plan members there? Yes, it can cause disruption when there's some restrictions, but we have seen nationally that Americans are willing to make the trade-off for care that is more affordable and higher quality. They didn't used to be. 20 years ago, I would have said that would never work, but I think healthcare has become so unaffordable that people are willing to trade off choice for affordability. And make sure you continue to join forces with other employers such as through the Alliance, because without it, you can see that the balance of power is not exactly even. And pressure the broader marketplace to evolve in the right directions, using your purchasing dollars well and advocating for effective policies. Where do we need a policy intervention? I think we need it when there are examples of the marketplace just being broken and no end in sight to that brokenness. The level of the playing field is not even. I love this picture. My son's a soccer player and it looks like it's so uphill to get to the goal. And there's very little antitrust enforcement. So we can't expect your state attorney general or the US Department of Justice to come to your rescue. It's not going to be enough to address these imbalances. But there are some policy changes that either are occurring or can occur. We have new laws at the federal level around price transparency and surprise billing that really will create more transparency and more fairness on the part of what your plan members will pay for care. And states have done some really innovative things that could happen in Wisconsin as well. Rhode Island caps the amount that health plans can raise prices that they pay to hospitals each year. So the health plans can say to the provider, sorry, I'm not allowed to pay you more than this. California has banned gag clauses, which are these clauses that health plans and hospitals would enter into that prohibited the health plan from sharing price information or quality information about certain hospitals. Massachusetts has banned contract provisions that prohibit steering patients to particular providers or tiering providers in a certain way. And Oregon has had a many-year experience with what they call coordinated care organizations, which are like accountable care organizations. And they've had direct relationships with providers rather than using traditional managed care plans. So there's a lot of innovation out there to look at. And to whatever degree Wisconsin needs policy intervention, you all have the voice to potentially make that happen. So with that, I will pause and see what questions there are.
Thank you, Suzanne. We do have several questions. The first, honestly, this is my question. We have known about the need for payment reform for so long. And while we've seen, different models occur in pockets around the country, this really hasn't taken off in a widespread way. And I'm just wondering why you think that is. Why do you think it's been such a tough slog?
Yeah, change is just hard, right? Especially if there is a party like a particular hospital or a physician group that is making good revenue and they know how to do the business that they're in. Let's say a service business. Changing that is a lot of work. If they suddenly have a budget that they have to manage for an episode of care for a patient for a year, they have to think about more than just the care they're used to delivering, appointment after appointment. They have to think about well, how could I keep someone from having to need to come to see me in the first place by keeping them healthy, or offering them a social worker, or something else that addresses some preventive needs or care management needs on an ongoing basis. They also have to really tap into their quality performance on a real-time basis, because if their payment's going to be affected by that, they're going to want to be able to track that. And they also need to be able to monitor their financial performance in a real-time basis beyond, maybe an annual sort of budgeting process where they understand what margin they need to make. And so they negotiate big contracts with that margin in mind. It's a lot of work. And I think it's just human nature to want to, stay, sort of happy with the status quo. And I think that's the biggest reason, just human nature and the work that it takes. On the upside for providers, many who adopt these new forms of payment love their newfound freedom, because instead of being on this treadmill of delivering services and billing for all those services individually, they now have some room to maneuver and use some creativity in terms of how they address the needs of their patients. And especially for those who really care about caregiving, I think it opens up doors, to doing things that they've wanted to do for a long time.
Yeah, so change is hard, but life can be better on the other side, as is often the case. I want to ask you a little bit now about your views on CMS. You shared what was happening with the Medicare Shared Savings Program and some of the results that they've had. Medicare, drives the bus. What Medicare does, providers pay attention to, and they really kind of set the pace. What do you see coming out of CMS that we could look forward to or dovetail off of?
Yeah, well, in the 11 years since the Affordable Care Act got passed and the Centers for Medicare and Medicaid Innovation got $10 billion to experiment, CMS has tried about 55 different payment models. And of those, they feel that about 5 were successful. So that's a lot of work for not a lot of reward, but that was work that needed to be done. And it helped prepare providers for understanding what it's like to receive a bundled payment or be part of an accountable care organization and subject to shared savings or shared risk. And that helped prepare them for the same kinds of programs in the commercial market, which was good for all of us who operate there. But I think what CMS plans going forward is to really focus on fewer models. They want to really address the issue of equity, which is great because we know that there are huge disparities among different races in this country in terms of their healthcare experience and outcomes. And they also want to work toward more multi-payer alignment so that commercial payers and public purchasers and public payers are all, using similar models and working toward the same goals, so that the signals to providers are a lot more clear. I think those are some of the things that we're going to see. Primary care is a big focus as well, trying to find models that can really support primary care to have a bigger role.
That's a big emphasis for us as well. So that's good to hear. That may open a door to be working more closely with CMS in various markets. Audience question or comment maybe in question is providers need to learn the concept of lean manufacturing and how it is that how to eliminate waste and improve processes. Manufacturing had to adopt these principles simply to survive.
Right.
What's your perspective on getting providers, getting healthcare to learn the lessons of manufacturing and adopt lean thinking?
Yeah, I completely agree with that statement. And there are great examples of health systems that have taken that to heart and have performed beautifully. One of my favorite examples is Virginia Mason Health System in the Seattle area. And they come out on top on quality metrics all the time because they adopted that 25 years ago. They're held up as a shining light all the time. And, I think it's probably spread to some degree. I mean, they're certainly not the only system that's done it. But I think part of why we need payment reform is because unless it feels necessary to undergo that kind of, re-engineering, hospitals aren't going to do it. As long as they are, making, enough money to keep afloat, and I'm not saying all hospitals are, but those that do, just don't feel the need. Now, why did Virginia Mason do it? Leadership, visionary leadership. And that's one of the things that always really, was an interesting takeaway for me when I was running the Leapfrog group. We tried to analyze, why did certain hospitals report and not other hospitals, and share information about their performance? Why did some perform well and some perform poorly? We tried to look for certain characteristics, and you really can't identify. You can't say, oh, urban versus rural, academic versus community, anything like that. It really comes down to leadership. And so that's a hard thing to, to clone. And so I think, we really need to sort of tighten the screws in terms of how we pay so that the pressure is there.
Your comments make me think of something that John Toussaint, a physician leader who led ThedaCare, a hospital system in the Fox Valley, used to say to us. They were an early adopter of lean. And this ties in benefit plan design. He would say, we're working our butts off to lower the cost and improve the quality. We have better outcomes and lower prices. And as a result, we're not seeing any change in market share. No one is, we're not seeing that shift. So all I'm doing is transforming our organization and getting less revenue. That isn't how this is supposed to work. So he challenged us to use benefit plan design and other strategies that the buy side has control over.
That's right.
To create market share that recognizes and rewards providers that do a good job and cost less. And frankly, that was the genesis of our Quality Path initiative. That was how that all started. It was in direct response to that challenge and feeling like we need to do our part to be sending care to providers that do a good job and cost less. I have a question. I have a question about direct-to-consumer approach to improve cost in healthcare. Maybe that means a consumer-directed healthcare. High deductible health plans where consumers are being asked to take more responsibility for making choices. Do you see that as being effective?
That's a great question. I mean, I'll answer it in two ways in case that's not exactly what the question poser meant. In terms of, I'll just say generally that we have learned over the last 20 years that giving information to consumers alone does not really change behavior. I mean, there'll be some small portion of populations like the engineers at GE, who love data and who will look at that stuff and make decisions based on it. Most consumers will not when it comes to healthcare. And they do need some kind of incentive tied to that information to get them to change behavior. High deductible health plans were used first and foremost by employers to save money, but also because there was this hope that it would create real consumerism in healthcare. That if, the first $2,000 were something that the consumer was in charge of, they would shop more carefully. Sadly, it was, I think, largely a failed experiment because what most data are showing is that people simply refrained from getting care across the board, whether it was care they needed or care they didn't need. And in fact, it's now been around long enough that there's some studies really showing some, frightening outcomes for people who were under high deductible health plans, more likely to have breast cancer go undiagnosed or to die from breast cancer, things like that. So I would say that high deductible health plans have run their course. They are still a great way to save money for an employer, and sometimes there is no other choice, or stop offering healthcare. But I think people are looking now at copay only plans and looking at different ways to create incentives, but not create such strong incentives that people don't use their health insurance.
I'm going to follow up. Thank you for that. I'm going to follow up with some other questions that relate to the role of patients and patient compliance and patient risk factors. The questions, if I summarize them and am interpreting them correctly, note that the characteristics of a patient, how sick they are, their comorbidities, et cetera, and how compliant they are with care plans can impact care delivery as well, and how much it costs to take care of that patient. How do you see that needing to be addressed in payment reform? What's the responsibility of patients, and how does that get factored in?
Right. No, that's a great question. I mean, I think there's no question that benefit designs and payment methods need to be aligned. So, for example, if we create a financial barrier for patients to seek certain services, let's use the example of someone with diabetes. Primary preventive services are covered before the deductible, but secondary preventive services, when someone already has a chronic condition, are not covered. So, for example, going to get that eye exam or the foot exam, things like that. Even paying for test strips, right? A person with diabetes still has to fork over all that money in co-pays for these secondary preventive services. So if we're holding providers accountable for patients getting their HbA1c tested and having good blood sugar control, but yet we're creating financial barriers to patients to doing that, it doesn't make sense. So we really need to think about how to line those pieces up very thoughtfully. And that's why I'm really encouraging all of you to think about your benefit designs, because that is something that you can impact, and it can make a big difference in enabling patients to do what they want to do. And, it's easy to look at this country and think, what is wrong with people? They're not taking care of themselves, and we need to, create incentives for them to take care of themselves. I think most people do not want to be sick, and they want to work hard to have a healthy life. And, but it has become so unaffordable to do so that we really have to act on that.
If we have time, I'm going to ask you a follow-up question there about the role of employers in helping employees stay well. I know that's kind of a tangent to this topic, but we got a question about that. I want to ask about another layer in the healthcare system. So there's what we as purchasers and payers, how we pay systems, and then there's the question of how systems pay their now employed doctors.
Yep.
And can you talk a little bit about the incentives inside of the health system? What is it going to take to make meaningful change there, given at least what we believe are misaligned financial incentives with inside of the healthcare system?
Yeah, this is an area that I think we all still know less about than we need to. And by that, I mean, it's a little bit of a black box. You're absolutely right. So there could be a health plan contract with an accountable care organization that has all kinds of quality metrics and a budget that the system has to adhere to, and financial consequences if they don't, et cetera. And the individual providers practicing may not even know it exists. They may not know what an accountable care organization is. And in fact, I'll never forget, in the early days of, or the precursor of payment reform, which was really the pay for performance movement, I remember stories in California of physicians throwing checks away because they had gotten some bonus payment that they thought it was, one of these fake checks that come in the mail, for something, and they didn't even know they were in the program. So this is sort of an ongoing problem. And I think we should assume that in many cases, the individual practitioners are not feeling the incentives that we're bringing to the system. I know, for example, within Kaiser Permanente, which is a big organized health system out here, physicians are still paid productivity bonuses, which is, counter to what you would think when a system is getting paid capitation, a single payment for a patient for a given period of time. So I think there's a lot of mysteries to unfold, and I don't know as much as I should, and none of us do.
You know, that is a really good point, and it's something that we've learned a little bit about ourselves just through personal conversations with real life clinicians. Again, thinking about when we set up the Quality Path program, I had the opportunity to speak to an orthopedic surgeon who said, I'll tell you how I get paid. I mean, just so you know, it might be interesting to you. 80% of his salary was based on RVUs, which is a measure
Right.
of resource use intensity. The more, the better. So
Yep.
the more stuff, the more complex stuff, the higher his salary. The
Yep.
other 20% was attributable to something he called capture, which is the amount of revenue he took in. So certainly RVUs played a part in that, but so too did the the reimbursement programs of the payers and plans of the patients he was treating.
Yep.
So
Yep.
he said, if I paid attention only to how I was paid, I would be incentivized to do a lot of complex stuff to people with good insurance.
Exactly. Yep.
Exactly what we don't want.
Right.
You know, so I think that was eye-opening for us to
Yes.
understand, notwithstanding all of the work we're trying to do to send a signal for higher value care to the system, we still have to get then physicians paid in a way that
Right.
that same signal matters.
Yeah.
Suzanne, I'm going to go back to the question that I referenced earlier. It came from someone who said, you know, employers are really struggling to keep doors open and manage COVID. And you noted the importance of people's own health and well-being. Do you have any thoughts, kind of, you know, separate topic, but related, how employees can do more to help their employees stay well?
Yeah, I mean, wellness is not my area of expertise. I'll just start by saying that. But the one thing I can say is that many years before COVID, we already had our members talking about the rise in their expenditures in the behavioral health area. So whether it is related to substance use disorders or anxiety, depression, stress, they were seeing, you know, the numbers of people getting these services rise and the acuity rising. And I'm not talking about serious mental illness like, you know, schizophrenia or bipolar. I'm talking about, you know, just sort of less serious, but still very concerning, you know, rates of anxiety, stress, and depression. And, you know, with COVID, obviously kind of skyrocketed. Now, I think the good thing about COVID is that one of the things employers have really struggled with is the stigma around behavioral health needs. And I think as a nation, we have moved a little bit further away from stigmatizing it. But I think that's an area that employers need to pay a lot of attention to. And it's a challenging area because there really is a shortage of care providers in particular. And there are a whole variety of interesting options now, from sort of, you know, digital to, you know, telemedicine, et cetera. So I think when it comes to wellness, you know, mental health is probably at the top of everyone's list right now as an area to pay attention to and to make sure that employees have adequate access to.
I have gotten a number of requests for slides. Just know, everyone, that we will make these available when we have them. I'm going to follow up or ask one last question, Suzanne, and that is, you know, what advice do you have for the Alliance as an employer-owned cooperative that's negotiating contracts directly with providers? Have any thoughts for us?
Yeah, well, I mean, I just want to share first, as Cheryl and Kyle know, we had funding from the Commonwealth Fund, a well-known, you know, national healthcare philanthropy, to look at options for employers and other healthcare purchasers to enhance their purchasing power and to, you know, identify potential models for the future to help counteract some of the, you know, the unlevel playing fields out there. And there were so few examples of success that we found, but the Alliance was one of them. So I just want to, you know, congratulate you guys on what you're already doing. But I think when it comes to payment and payment reform, you know, what I have seen happen nationally is that payment reform starts in a way that is palatable to providers, and pushes them more and more over time. And so depending on where you're starting from, it's imperative to get started or to move to the next, to have a glide path that you've envisioned for how you will increase the potency of incentives over time, and work with providers to do it in a way that's sustainable, because you don't want people quitting, and saying, I just can't do this, but also, adds pressure. And, you come with the advantage of many, many covered lives in your market. And, I think it just takes a lot of perseverance and, understanding where each provider is starting from and pushing them along a continuum as they are ready and have the infrastructure that allows them to do that.
Thanks, Suzanne. Your comments have been great, and we so appreciate you being with us here today. And we so appreciate the partnership that we have with Catalyst for Payment Reform. You guys provide such thought leadership on this topic, and moral support, because as you know, it's not easy. So we really appreciate your participation today.
My pleasure. I so appreciate the opportunity.
So next, it's my pleasure to introduce Kyle Monroe. Kyle is our Vice President of Network Strategy and Value Measurement at the Alliance, and Kyle and his team are working on behalf of our members to implement many of the strategies that Suzanne just covered. They're focused on our goal of getting high quality healthcare at affordable prices. And I'm now pleased to welcome Kyle to share the progress that we're making on your behalf in this area.
Good morning, and thank you, Cheryl and Suzanne, for a wonderful introduction to my presentation here this morning. Really could not have teed it up any better, and you're going to hear a lot of common themes. And I just want to reiterate my gratitude for Suzanne and the Catalyst team for working with us at the Alliance and really helping us develop a lot of the strategies that we've put in place. As a member of the Alliance, not only do you have access to wonderful resources like Suzanne, but you've got a team at the Alliance that's helping you implement those. And it's my pleasure this morning to be able to elaborate on some of those ways that we at the Alliance are helping employers move the needle on payment reform. If you take nothing else away from today's discussion, I really want you to know that how we buy care matters. You heard Suzanne say that, and I'm going to try not to use that phrase too much, as Suzanne said, because there's so much, there really is a ton of overlap here. But how we buy care matters. If you think it's only about money, simply not the case. We're going to go through some reasons why there's a lot more at stake here than just the value of care and then a dollar. To that end, it's my privilege to share with you some of the ways the Alliance, and more importantly, Alliance employers, are taking actionable steps to reform the way that we buy care. Oh, let me make sure we get our slide up here. We got it, Paul? Thank you. Payment reform is one of the 4 core drivers that employers can use to help drive more value in healthcare. Why does that matter? The concepts of the 4 core drivers were originally established by Suzanne and her team at Catalyst for Payment Reform. Both Cheryl and Suzanne covered a lot of this in their presentation, so I won't spend too much time recapping. But I think it's valuable to talk about, again, why does this matter? Why is this important? Payment reform, again, is one of the main ways that we in the buy side of healthcare can exert our influence to the sell side, right? There are very few of the ways that we can do that, and the way we pay absolutely matters because it influences the behavior of clinicians and hospitals. To many employers around the country, payment reform is aspirational. They're unable or unwilling to change the status quo. As Suzanne mentioned before, that there has been a study recently by the Catalyst for Payment Reform that talks about the progress of payment, and to her, the results of that study showed that largely employers have struggled to implement some of these things. And I'm proud to say that that's not true for Alliance employers. It's not been true for Alliance employers throughout our history. Payment reform is a journey the Alliance has been on for over 30 years. We started with something called as simple as inflation controls, which at the time were very novel, right? Providers increased their charges year over year, and the Alliance said that's not acceptable. So early on in our founding, we decided that we didn't want to pay for healthcare the way everybody else was paying, that we needed to take additional steps to increase value. And again, at that time, the idea of capping the amount a provider could increase their charges was novel. And so these are things we've continued to explore throughout our history. A little bit of updates on the Alliance's network. We're continuing to work with employers like you to change the way that we pay for healthcare. One way that we do that is to continually make improvements to our provider network. As you can see, we now work with over 32,000 individual medical professionals, over 135 hospitals with 7,200 clinic sites. Our clients have purchased over $900 million in healthcare, which generates over 40% of that in savings. We now cover a majority of service areas in Wisconsin and a large proportion in Illinois as well. You heard Suzanne speak about some of the challenges that COVID has brought to the delivery systems and to access of healthcare. One of the most important ones has been behavioral health. We've heard the concerns of Alliance employers about having some challenges getting into or being able to see behavioral health. So we've focused on adding more clinicians that can support access to behavioral health services, which is why in the last 12 months, we've added 110 new behavioral health practices, which include over 850 clinicians. And that's all been within the last 12 months. And again, that really is to support the overall expansion of our network, as well as the needs of your employees. We continue to grow the network where you, our employer partners, have spent. We don't grow just to grow. As you can see here, we've added 4 new hospitals, over 100 new clinics, and over 900 other new physicians around the state to support where Alliance employers are already buying care. We'll work with you and your brokers throughout the year to continue to add and evolve the makeup of our provider network. And again, it's not just add anyone or anytime. We really do work to find where there are needs by you and your employee populations, and then work to address those. Suzanne showed a version of this slide in her discussion, so I don't want to spend too much time here, but there are a few things that I want to remind you of as we're continuing this discussion this morning. The payment continuum is important to understand that and again, as moving from left to right on this continuum increases accountability and transparency on behalf of providers. All payment methods have inherent strengths and weaknesses. One of the big things I wanted you to remember this morning is that no one size fits all. There are no magic bullets, right? As much as I'd love to sit here and say, you know, we found the one thing that's going to fix all of the healthcare, all of our healthcare issues, it doesn't exist. And so what we do at the Alliance is we take a market by market approach, and we deploy the most advanced payment methodology that we can get. You know, we're really looking for things that are predictable, simple, and transparent. Employers need flexibility. They need the flexibility to design benefit strategies in a number of ways that continue to promote value and that are tailored to meet the individual needs of their population. At the Alliance, our networks are platforms on which employers can innovate. Suzanne mentioned some of the some of the challenges that purchasers have had, and some of the contract provisions that have prohibited or precluded employers and purchasers from implementing some more advanced payment reform. I'm proud to say at the Alliance, our contracts don't include things like anti-tiering, anti-steering, or gag clauses. We won't agree to those We would never agree to those because they inhibit your ability to drive more value and to do innovative and to deploy innovative strategies on top and using our networks. So those aren't things that Alliance employers have challenges for. And if you're interested, as we've said before, as I've shared with you, many of you before, we'd be happy to sit down and discuss what's in our contracts. As a member-owned cooperative, these are your contracts, and if you're interested, what's in them, what they say, the contracting team at the Alliance would be happy to help walk you through and see what's in those. Payment reform should encompass aspects of all of those 4 core drivers of healthcare. So you're going to hear as I move into what are we doing to impact payment reform. You're going to hear me come back to things like transparency, the integration of transparency into payment, the integration of benefit design into payment reform, the integration of network design into payment reform. And those things, again, there's intersections between all 4 of those core drivers. As I mentioned, the concepts of simplicity, predictability, and transparency are foundational for us. Simple for purchasers and consumers to understand. We need to make it easier to compare providers from different geographic areas, and we'll talk about some ways that we're doing that. You can have complex mechanics, meaning, the way that the healthcare can be paid, to Suzanne, can be complex if there's lots of different payments or fees or negotiated quality metrics that are incorporated. Those things can be complicated, but how do we do it in a way that's simple for people to understand is something we continue to ask at the Alliance. Predictability. They need to be more predictable for individual services and more predictable for employers over a duration. More predictable medical cost trends year over year. These are all things that payment reform needs to accomplish. Finally, and again, increased transparency. We need transparent data, we need transparent cost information, and we need transparent quality information to be able to interpret and to be able to buy care more efficiently. Before I get into exactly how the Alliance is doing, I wanted to take a second to remind everyone how Medicare pays. Now, why is what Medicare pays important? Well, Medicare payments methodology is the foundation of how the Alliance pays. So understanding how Medicare pays is important to understanding how the Alliance pays. As a reminder, Medicare is the largest individual purchase of healthcare in the world. They purchase nearly $1 trillion in services annually, and that continues to go up. There are some basic reasons why we want to start with using a Medicare referenced agreement. And again, this is different than reference-based pricing. What we do at the Alliance is we call it reference-based contracting, because our contracts protect individuals and employers from things like out-of-network bills, surprise billing, but they do so in a way that references Medicare, right? So you're accomplishing many of the same things that a reference-based pricing approach would take, only you're doing it where you're working proactively with the provider to come up with a more sustainable long-term solution. So Medicare really has a few basic components. There's a base rate. The base rate really gets us off of a provider's bill charge, because the base rate is what it costs for the provider to deliver that service plus a small margin, and that's what how Medicare determines what the base rate needs to be. So instead of starting at bill charge, which could be an arbitrary number set by the provider at any rate, we really want to look at what did the service cost to deliver, and that's what Medicare, basing our methodologies on Medicare, allows us to do. There are also provider-specific adjustments, and this is a way to begin to start incorporating quality into our purchasing. It's also a way to be able to tailor payment to a specific geography, because in the provider-specific adjustments, sorry, it's a little tongue-tied, that one. The provider-specific adjustments include things like geography, so costs of living of an area, the overhead that it's expected that the provider needs to have to provide care in that area. It also includes value-based components, like things like hospital-acquired infections or readmission rates. And Medicare will, and then sometimes does, penalize hospitals if infection rates are outside of expected norms, or mortality rates are high, right? So we think it's good to know, and we think it's appropriate for commercial purchasers for us to be able to say, you know, if just like Medicare does, if there's a higher propensity that by going into that facility down the street, you're gonna be readmitted, then there needs to be some transparency, and candidly, we're going to be including that into your overall payment, right? So this is a way that we're starting to move towards more value-based payment and incorporate quality components into the way that healthcare is purchased. I want to remind everyone, and if you haven't heard, but many of you may be familiar with the RAND study on hospital pricing. We had the folks from RAND here present at our annual meeting last year, and the RAND study was a study that looked at hospital service pricing in markets across the country, and they did so as a percent of Medicare. So as you can see, these things start to build on each other, right? So now we know what percent of Medicare is. Well, how does Wisconsin look as a percent of Medicare compared to other states in the country? Unfortunately, as you can see here, Wisconsin is the third highest cost state in the RAND study based on percentages of Medicare. Statewide, again, it's about 350%, and that includes geographies and payer and includes data from a number of purchasers from across the state. So again, we've got a ways to go. Prices vary greatly across markets, and sometimes for valid reasons, but there's not a valid reason for the discrepancies that you see in front of you. But simply cutting prices to the bare bones isn't the right answer. As we talked about earlier, you know, what we do at the Alliance is different than reference-based pricing. We aren't suggesting that an employer take the step of just saying, well, we're going to pay 150% of Medicare because that's what other states are paying. That can be very problematic for an employer, for a patient, and at the end of the day, might even prohibit more progressive dialogue around payment reform. We need to work collaboratively with our provider partners in ways that protect employee financial and physical and mental health while preserving access to high quality health care. We also want to continue to promote sustainable provider community so that your employees have access to high quality care where they live. As I mentioned, our foundation of our payment strategy of the Alliance starts with reference-based contracting, where pricing is benchmarked to Medicare and agreed to by our provider partners before care is delivered. I'm happy to report that in 2020 and through 2021, over 90% of the claims flowing through the Alliance's contracts are paid at a percent of Medicare. For hospital services, Alliance contracts range from 175 to about 275% of Medicare. Not perfect, but we are doing much better than the statewide averages according to the RAND study. As you can see, we are continuing to make more progress on our strategy to use reference-based contracting as a foundation. The graph in front of you shows the progress that we've made since 2017. As I mentioned before, this has been a journey the Alliance has been on. We did not just start this last year. This has been something we've been working on for a number of years. And again, we continue to make progress here. Getting close to 90% on a number of Medicare-based agreements by quarter. This is even a higher number if you look at the number of claims flowing through these agreements. And so we're monitoring how we're doing on not only the number of agreements, the number of claims, and the number of dollars. As I said before, Medicare at reference-based contracting is one strategy that we're using. However, as I said before, there are no magic bullets. So what else are we doing? Some clinical services are more appropriate for other methods of payment reform, like bundling. We're certainly offering bundled services at the Alliance. But I think it's important, something else to remind everyone is that, again, bundles aren't necessarily new for the Alliance. I'm going to talk in a minute about Quality Path and remind you all about what we've built with Quality Path and how it aligns with our other bundled provider strategies. Bundles aren't new to the Alliance, as I've said. Bundles can be very valuable if designed correctly. Bundles can promote reductions in clinical variation because providers are no longer tied to fee-for-service payments. This is where we get into how we buy care matters, right? If we want a different outcome, if we don't want providers, and Suzanne, I thought, hit this on the head when she said, you know, if you're paying fee-for-service, a lot of what you're getting is more services. Well, if we don't want to continue to get more services, and we know that there are clinical services that are appropriate to package together and pay one consistent price for, then we should do that. And we need the systems and the contracts to support it. So that's what we've done at the Alliance. You know, we've built and designed and work with providers who built bundles. Now, not all bundles are created equal. Okay, I need to be clear. And just because it's a bundle doesn't make it necessarily better than what we had before. So be careful of, you know, of being sold a bill of goods that, hey, just because it's a bundle, it's better. You know, one of our roles at the Alliance is to work with our provider partners to develop and identify opportunities to bundle services where employers and patients have needs. So where your employee populations are buying care that is appropriate to bundle, then that's where we'll go work with those providers and establish bundled pricing for those appropriate services. Because ultimately, we're looking to provide more clinical and financial value. It's got to be both. Otherwise, what are we accomplishing? It can't just be a one side of that coin, right? As we've said before, it's about outcome and quality as well as price. Currently, Alliance employers have access to over 350 bundled services. We've got, with more on the way, right? And so we've listed a few of our very good bundled partners up on the screen here, and I'd just like to reiterate our gratitude for working with them. Novo Health, Minnesota Gastro, Twin City Orthopedics. These are organizations, provider organizations that have worked with the Alliance to deliver services in new ways and to build them in new ways and to provide not only that, but to provide care in new ways. I think that's really, you know, the most important piece here is it's alignment across the continuum for the provider, for the way it's purchased, and for the employee and the patient, which really aligns well with how the Alliance developed Quality Path. Quality Path offers a lower price and a warranty for higher performing providers for select surgeries and tests. We've listed up here the services as well as our partners for Quality Path. And again, you know, Quality Path has been was something the Alliance developed over 5 years ago, and it was our first foray into bundles. And so we've built on our expertise in this space. We've built on what we've already learned and continue to deploy that with new and allow for new bundled options for employers. I want to spend a few minutes talking about the future of payment reform, because we've come a long way at the Alliance. And as I've said, as I showed already, we're deploying new ways and we're combining methods of payment reform like percents of Medicare with bundled pricing, but we're not finished. We've come a long way, but we've got a long way to go, which may sound weird, but give me a second, right? Bear with me. Transferring financial risk to entities and provider organizations is important, and we've talked about that. And if you go back to my payment continuum slide, where the further you go from left to right increases accountability and transparency. Moving to the right on that continuum really is about the transference of financial risk. That's a big piece of it. Transferring financial risk is what ultimately leads to the transformation in the clinical care and the way that the clinical care is delivered. Total cost of care contracting is one way that you can move to the right on that continuum exponentially faster. Total cost of care contracting really, and Suzanne alluded to this, is you would be paying a fixed fee, whether it's a per member per month, per member per year, per employee per year. There are a few ways to go about it, but that you're really paying a fixed rate for all of the care that would be delivered in that arrangement, right? Fixed payments at regular intervals over time. The provider assumes financial risk for treating the entire condition, patient, or group of patients. Total cost of care contracting requires robust and transparent data and analytics. And we're investing in those capabilities right now at the Alliance. more robust data, more transparent data, more sophisticated reporting and analytics that will allow us to continue to move down the continuum towards more innovative payment reform strategies. The other thing it requires is an intimate relationship with provider organizations. That's an underlying facet of this that I think does not get enough credit. That having a very good relationship with the provider organizations is critical to implementing more holistic and payment reform strategies, as well as total cost contracting. Because otherwise, how do you know what's happening to the population? How are you guaranteeing that not only are you getting better financial outcomes, but you're getting better quality outcomes for the patients that you're paying for? How are you making sure that they've got access to the care that they need? So there are a lot of questions that go into total cost of care contracting that we're working and building capabilities to answer. I think telehealth is also going to be a very strong component of the future of payment reform. Telehealth, digital services really have been thrust into the limelight since the pandemic. And there's been a lot of research on this. The number of services being offered in telehealth have gone up 25 to 30% over the last just even year, meaning the number of providers that offer care on one of those platforms. The number of individuals seeking care in telehealth platforms is up hundreds of percents over the last few years. So this is this is an area that continues to grow, but also an area that continues to need refinement and how is it integrated with a broader strategy of payment reform as well as benefit design? What does it enable an employer and a patient to do? And if you're not redesigning the way that you pay for care in conjunction with the telehealth services, are you really just adding another way for care to be delivered inefficiently and in a costly manner? An example of this would be if a provider offered telehealth services but was going to continue to charge the same price that they were charging for an in-office visit. Well, that just doesn't make sense. So how you align and design strategies with telehealth are certainly interrelated to the strategies of payment reform that we're pursuing, as well as the other strategies of the 4 core drivers. We also want to integrate, we want to build on the Alliance's strong history of focusing on quality by integrating quality even more deeply into our payment reform strategies. I talked a little bit earlier about how we've integrated quality into percents of Medicare. We also integrated some deeper quality metrics into our quality path program. Quality metrics that require providers to submit data to registries that can be used to understand the care that's being delivered. Quality metrics that guarantee the patient has a voice in that room with the clinician. So we're going to continue to build on our strong history of quality that integrates quality into the way that we buy care. We need information that facilitates and promotes action. Actionable information for patients because they deserve to know that if they choose the hospital down the street, they have a 15% higher chance of being readmitted, or God forbid, having an event that they, someone passes away from, right? Their mortality rates at hospitals are very different. And that's not something people talk about a lot. But if you have a 3% higher mortality rate of going to one hospital or another, that means 3% of the people that are going to that hospital have a 3% higher chance of dying. Well, we need to know that. People need to know that when they're making these decisions. Actionable data also means actionable for providers and clinicians because it gives them new access to information that can improve the quality of care being provided. So it's not just about, as a purchaser, having that information at our fingertips. We want to be able to provide high quality information to providers that'll help them improve the care that they deliver. It's not about playing gotcha or trying to measure someone on and not be transparent about it. We want to work with providers in ways that drive lower costs, improve value, and improve the quality of care that's being delivered. We also need metrics that are actionable for the Alliance because it allows us to incorporate them into our provider contracts, right? As well as so again, we're back to our 4 core drivers here, right? Of payment reform, quality information. We need good quality information to be able to design networks effectively, to be able to design benefits effectively. So these things all intersect. To do that, we must first define those measured things that are most important to us. How well are patients with chronic disease measured, or how are they managed? How often do patients avoid surgery altogether because the provider helped find a less invasive and ultimately less costly treatment? What's the functional health status of patient populations specific to spine care after surgery? Right, so these very specific questions that we're looking at of how do they lead to better outcomes and how do they lead to a better health for an individual after they receive care? These are important things to know for us to understand as our expectations of purchasers are being met. Now, early on, I mentioned that there was a couple of key things. And if we were in person, I would walk around the room and I'd quiz you on some of those things that I said I really wanted you to remember. The most important thing that I think that I'd ask you to take away today was what? It's that how we buy care matters. The way that healthcare is bought and paid for influences the care that we get. That is the most important takeaway for today, and I ask you to hold on to that. Right? Medicare-based contracting eliminates exposure to provider charge masters and increases transparency by allowing purchasers and consumers benchmark pricing across providers. Bundles are another great step that begin to transfer financial risk away from employers and on to providers. When designed and implemented correctly, bundles can lead to better quality through reduced clinical variation, reduced complications and revisions, and standardized patterns of care. At the end of the day, payment reform is critical to improving healthcare value. Done well, payment reform can lower costs, improve transparency, and lead to better outcomes for patients, employers, and for providers. With your support, the Alliance has already made great strides in reforming how healthcare is paid for. But I'd like to end with a quote, and I'll leave you with this. Winston Churchill is someone I love to read about and study, and one of his most famous quotes, it was right as the Battle of Britain was getting underway, and he said, "Now is not the end. Now is not even the beginning of the end, but it is perhaps the end of the beginning." And that's where I feel like we are in our payment reform journey, right? This is not the end. We've not found the end. We've not even begun to start the end, but we've come a long way, and we're ready to start taking those next steps. I want to thank you for your time this morning, and we'll now open it up for questions from the audience. And I see we have a few coming in. Okay, so the first question that we have is, what do providers think about payment reform? It's an interesting and a nuanced answer. Payment reform can tell, our payment reform conversations can really tell us a lot about a provider organization's willing to partner, right? Many provider organizations are already taking steps to improve value for patients and employers, and we're already working with some of those organizations. We showed them on the screen earlier. Our partners at Novo Health, our partners at Ortho Illinois, right? Those organizations are already doing things differently. I'll be honest though, others are sitting on the sidelines, right? They want to see if employers and patients really care about this stuff. If payment reform is important to patients and employers, then their opinion is patients and employers will start doing something different. And if patients and employers don't do anything different, then I think we'll have a large contingent of providers that continue to sit on the sidelines. And so, right, to Suzanne's point of your engagement matters here. And it's going to help us continue to move the needle. We got a couple more coming in. Okay, are there limitations to things like bundles or Medicare-based contracting? Yes, there are, absolutely. And as I mentioned earlier, there is no one magic bullet here. There's no one solution that's going to fit everything for everyone. Local market dynamics can and do certainly play a role here. Critical access. Let me back up and give you an example here. Critical access hospitals, right? The hospitals that are determined to support more rural communities aren't paid the same way from Medicare that an acute care hospital or an academic medical center, right? The way I walked through the way Medicare pays with you is how an acute care or an academic medical center are paid. That's different for a small critical access hospital. So saying just, use percentage of Medicare for a critical access hospital doesn't or may not perfectly align with what's best for the community. So that's where, again, some of the local dynamics certainly take a role. There's, depending on what's the clinical services that are offered can also influence the type of payment that works best for any given market and any given service. We've got a few more here coming in. How do you solve for challenges of adapting Medicare quality to commercial populations? Great question. That's something we come back to a lot of, that there are some aspects of quality measurement that don't or may not be appropriate to apply for two populations. So what do I mean by that? Do we want to look at things the same way for a traditional Medicare population, which is over 65, right? Like it's an older population versus a commercial population, which may range from 18 to 60 or 18 to 65. The needs of those populations are oftentimes different. In some ways, they're not, though. So what we do is we really go through and we try to take a more granular look around, are there things we can take from and learn from Medicare? And again, one I come back to is mortality. Mortality and central line infections. Those are two that really aren't dependent on the age of the patient. They're really dependent, and the research shows that it's about the processes that the provider has in place to prevent those things. And if the processes the provider has in place are sound, then they're going to prevent them not only for a Medicare population, but for a commercial population. Conversely, if those processes are unsound, then you're going to see higher propensities of readmissions, of mortality, and of central line infections across Medicare populations and across commercial populations. So we understand there's nuance there, and but that's one of the areas we're continuing to probe and explore as to where we can take what we can learn from Medicare, where we can adopt appropriate strategies that align with what Medicare is doing, but also acknowledge that some of them might not. And then, so what do we do about others where they don't? Timely payment can, so moving on to another question here that's coming in from the audience. Timely payment can be a struggle for providers. How are you addressing this barrier to contracting with high value providers willing to contract on total cost of care and outcomes? Yeah, so one of the things that we want to do, right, as we've talked about as partners of our providers is, if we know that providers are going to be provide more value, that we can make payment happen faster. And we've got examples where we're doing this, where for providers who qualify for and have done things and have met our criteria, that they are paid more quickly than providers who haven't or who aren't working with us in as integrated of a way. And so this is one of the things we hope to continue to lean in on more, is to be able to find and work with providers that in ways to eliminate some of these barriers, right? Eliminate barriers to payment reform. One of those barriers to payment reform is that it takes longer to get paid. Well, then let's solve for that. And we're willing to do that. And this is what Deb Comferman and her team do all the time, which is sit down with our provider partners and find solutions to these challenges. Another question from the audience. You talk about reference-based contracting and reference-based pricing. Can you go back through what the difference is? Yeah, and I think this is important. So I wanted to, this is a really good question. In terms of percentages, reference-based, as I mentioned, our reference-based contracts at the Alliance make up the foundation of our contracting strategy. Reference-based contracting is about agreeing to something prospectively with a provider that they and we understand the terms of engagement. Reference-based pricing is a term that has become applied across the industry for pricing that is applied without a contract, without an agreed upon rate, and that can candidly lead to some really compromising situations. It can lead to litigation, it can lead to balance billing, it can lead to surprise bills, and doesn't always provide a lot of protection for a patient and employer. So as I said before, and I want to reiterate, we are not talking about reference-based pricing. We are at the Alliance do reference-based contracting, which, in my opinion, achieves many of the benefits of reference-based pricing, but add so many more because we do it prospectively. So we're working with our provider partners on behalf of you, the employer, to come up with a price that's benchmarked at Medicare, similar to how reference-based pricing works, but also provides the protections against the out-of-network billing, against surprise bills, and really, again, is a more collaborative way of reaching those benchmark reference-based agreements. Oh, we've got a few more coming. By the way, first, thank you so much for all these questions. This has been fantastic, and this is really what we were hoping to get to. So thank you for submitting all these. Next question, how can broker compensation be changed to incentivize savings rather than claims volume? That's a good question. I think the way that brokers are paid, we can apply many of the same the components of how we're buying healthcare to how we're working with all of our partners, right? And this is something we're also doing at the Alliance, right? Paying fixed PEPMs, right? To eliminate any incentive for volume or claims based, and provide more transparent ways of payment, of saying, here's going to be fixed pricing regardless of what's done. We want to move towards payments that are not based on volume or not based on charges, right? Moving away from those things, whether it's with a provider or a broker or any partner that you're working with, I think are questions that should be asked right now. And does that make the most sense? And how do you get there? And how do you make sure that you've got transparency and alignment into how who's being paid what? And asking that question on behalf of the providers is absolutely the right question to ask. It's also the question that should be asked across your partner continuum. I'm looking at questions here. What role do you plan to take in changing the narrative from unit pricing to pay for outcomes, and how that impacts and how outcomes impact the total cost of care? That's a great question, and something we're already doing. As I mentioned earlier, we've got a really robust analytics team. And our analytics team, one of the things that we look at is what we call, episodes of care. And it was episodes of care, and what's inside an episode of care? Episode of care is really about payment. It's about the number of services that are utilized to complete that episode, and it's about the quality metrics and the outcomes that are produced. And we're early in this work around being able to measure these things, but this idea of incorporating all three, and then having that kind of irrespective of payment, or of the contract. Because what we want to do is, now that once we're able to measure all three of those individual components, right? The way the healthcare is paid for, how the service is delivered, and what the outcome is, then our goal is to be able to start building those into agreements, right? Longer term. So that begins to move us away from this idea of, well, how much did the one piece of my healthcare cost, and how much did the whole thing cost? Let me give you an example. Maternity, right? And we know obviously maternity is going to be over a duration of 9 to 12 months. Well, instead of wondering what the individual ultrasound is going to cost, shouldn't we be looking at what all 9 ultrasounds plus the hospital plus the delivery plus all of those aspects are for maternity, right? And look at that as a bundle. So instead of us going and recommending, or anyone going and recommending, we should be looking at what's the best unit price for this ultrasound. That's probably not the right question. The question needs to be, what's the continuum of care look like for this episode, and how does it all fit together? And so we're moving in that direction, and we're building software and reporting packages that allow us to do those. Okay, it looks like we've got one more here. What can employers do to help the coalition in payment reform? Love this question, so thank you. And I think Suzanne touched on a lot of this again, but I would say the most important thing from my perspective is to encourage your employees to use high value providers, right? I mean, that is the strongest way for us on the buy side to influence and exert our opinions, right? And we've got to vote with our feet. That is the best way to do this. Acknowledging that means that benefits have to change, right? Communication strategies have to change. There's a lot that goes into changing the way that we buy care and changing who we buy it from. But that's ultimately what we have to get to if we want to change the dynamic and change the paradigm here. There are no magic bullets. Health policy certainly has a role, but I wouldn't advocate that we sit around on our hands and wait for health policy to take effect. I think we have actionable things we can do, and I would encourage you to reach out to your Alliance team member and working with your broker, and we'll bring some of these ideas and we'll help put together strategies that can move and continue our progress here. Because as I've said, this is a journey the Alliance has been on with our employer partners for a long time, and it's going to be critical that we continue to work together if we want to continue to move this initiative forward. I don't see any other questions right now. Again, happy to answer more if things come up. I would encourage you to reach out to us at the Alliance if you have questions. Thank you for your time this morning, and thank you again, Suzanne and Cheryl, for the wonderful setup.
Kyle, thank you. And we're going to shift gears now and move into our business meeting. And here to kick it off is Diana Clark, who is our board chair this year. Diana, thank you so much for your leadership.
Thank you, Cheryl. Good morning, everybody, and welcome. It's a pleasure to chair the board of the Alliance. Our first order of business is to approve the minutes from last year's annual meeting. All members of the Alliance, please select your response using the poll function on your screen. If you're not a member of the Alliance, please select I am not a member. I'm going to pause while we await the results. All right, thank you. The minutes have officially been approved. Thank you all. Now that the minutes are approved, I'd like to take a second to welcome all new employer members to the Alliance. Since our last fiscal year ended on May 31st, 2020, we've added nearly 50 new members. That's pretty incredible considering that we're in the midst of a pandemic. Welcome to the Alliance, and we look forward to working together with you. I'd also like to announce the results of our recent board election. The following board members have been re-elected to 3-year terms. Brad Olm, Vice President, Shared Services for Gordon Flesch Company. Jake Nolan, Vice President, Human Resources at Rice Lake Weighing Systems. And Shirley Reif, Secretary Treasurer for Crest Foods. We'd also like to welcome the following new board members. John Stevens, Chief Strategy Officer at WPS Health Solutions. Dan Ludwig, Director of Benefits and Safety at Breakbush Brothers. And Wendy Whitehead, who is the Director of Rewards and HR Service Delivery for Quick Trip. On behalf of the membership of the Alliance, thank you for your willingness to share your time and talent as board members. I look forward to working with you. Finally, I would like to recognize Wendy Culver, Chief Human Resources Officer for Mead and Hunt. Wendy is cycling off the board at the end of this year. Wendy joined the board in 2008 and served as board chair in 2017 and 2018, and then was pressed back into service in 2020 when Larry Preble, who was chairing the board, retired. Wendy, you and Mead and Hunt have been strong supporters of the Alliance. Mead and Hunt has been a member since 1993. We have benefited from your leadership and friendship. We're grateful for all that you have done for the Alliance. I'd now like to introduce Paul Meyer, Chief Operating Officer of the Alliance, who also serves as Board Treasurer. He will provide a report on the financials for this past year. Welcome, Paul.
Thank you, Diana. It's good to be here once again as the treasurer presenting this report. I've been doing it for a number of years. Let me just make sure I got the screen set up properly. There we go. So we appreciate your help and your support, Diana, as always, as we do our entire board of directors. So what I'd like to do is just start with a reminder about what it means to be a cooperative. A cooperative is a type of corporation where its members own the company, where an employer, the member, joins the alliance. When they do, they become a partial owner of the company. They elect a board to represent their interest in working with us, the staff, to meet the needs of the membership. The profits of the company are generally not taxed. They're distributed back to our members. This form of a corporation was chosen by our founders to assure that we're focused on serving our members, not investors and remote shareholders. This is a really important distinction in our market where healthcare providers, for example, have opportunities to work with many different parties, including large health insurance companies, many of which are very large, located far, far away, with shareholders also located far, far away. Healthcare providers know that when they are dealing with the alliance, they're dealing with local employers unencumbered by mixed incentives. In other words, it's clear that we work for you. Our membership purchases about $900 million in healthcare. We are an important part of the market for sure. So being organized as a cooperative, very much a unique characteristic of the alliance. My role as the treasurer here today is I'm giving you a financial report in your role as owners of our company. Unfortunately, just like last year, you're going to hear me today talk a lot about the impact of COVID on our financial performance. We're really no different than most companies. COVID presented its significant challenges, but we were and are well positioned financially to get through it, as this financial report will show. Paul, I'm having a little bit of a challenge in advancing the slides. There we go. So as I said, I'm presenting to you as an owner. And if I'm an owner, I would want to know how we're doing as a business. Are revenues covering expenses? Well, this slide shows the revenue and expenses by fiscal year for the last 10 years. The tall bar is revenue. The next bar is expenses. The difference between the two is net proceeds or profit. Our fiscal year is June 1. So for example, FY21 was June 1, 2020 to May 31st, 2021. You can see that revenue bumped up to about $9.2 million in FY21, and expenses decreased pretty substantially to about $7.5 million, resulting in net proceeds for the year of about $1.7 million. To understand the revenue increase, we need to look back to the prior year. In FY20, we saw solid membership growth, but revenue was down as a result of the pandemic, which really began to hit us in about March of 2020, which was still in FY20. Much of our revenue is driven by healthcare utilization. We charge a share of claim savings for our services. If usage of medical services is down, then our revenue is down. We saw a decrease in the use of medical services because people put off getting care, or providers limited the care that they would provide so that resources could be freed up to serve COVID patients. We saw a decrease of medical services of about 25% from March through June of last fiscal year. And that's why we had the small loss for last year. As we planned for FY21, we assumed that medical utilization would rebound somewhat, but it rebounded much more than we thought, which drove higher revenue. The other thing contributing to higher revenue was the forgiveness of a PPP loan, which was about $775,000. When that loan was forgiven, it was recognized as revenue to the Alliance. On the expense side of things, we took steps to lower expenses in FY21 because at the time there was so much uncertainty about the impact of the pandemic on our financials. With respect to net proceeds, and this is the characteristic of the Alliance being organized as a cooperative, most of the net proceeds are returned to members in the form of cash or allocated equity. In the cooperative world, this is called patronage. Each year, along with our board, we consider future financial needs and determine how much of the net proceeds to retain as allocated equity and how much to return in the form of cash. This year, the board of directors decided on 43% of the patronage to be returned in cash and 57% remaining on our books as allocated equity, with plans to put those monies toward ensuring we have a healthy reserve and investing in services that will help you to reduce medical costs. For those employers, members in the audience today, you or a representative from your company has received or will shortly receive a check to your company that represents your portion of the patronage for fiscal year 21. This is a graph based on our balance sheet. It's a snapshot in time of our books as of the end of the fiscal year, which, as I mentioned, is May 31st. It shows total assets, liabilities, and the difference, which is equity. Overall, what you're looking at is the balance sheet of a very healthy company. Assets exceed liabilities by a healthy amount. With respect to FY21, assets increased as a result of higher net income. Liabilities are down because the PPP loan, which we carried last year as a liability, was forgiven. This is a good time to mention that our board hires an audit firm to audit our financials on an annual basis. Like all other years, we received assurance that our financial statements accurately portray our financial position and that our record keeping is strong. To a large extent, our success depends on being a significant part of the healthcare market. We've grown from the original 7 employers who helped to form the Alliance to just over 300 employers representing about 100,000 people in an Alliance affiliated plan. Our members spent about $900 million on healthcare services last year. With this kind of membership representing this kind of dollars, we're definitely a significant player and have the attention of the market, whether that's with providers, TPAs, brokers, PBMs, etc. This graph goes to the heart of a very important component of our mission, and that is to help our members control costs. This graph shows the medical claims costs after our contracted rates are applied. This is the cost associated with providing care to the over 100,000 people enrolled in an Alliance affiliated plan. It's calculated by taking all the claims we receive for hospital, clinic, ancillary services, applying our contracted rates to get a net amount, and dividing it by the average number of people enrolled in an Alliance affiliated plan. In FY21, the amount was $524 per person per month covered by an Alliance affiliated plan. Our goal is to help you manage this cost. You can see the increase back in FY15 and 16 with moderation in 17, 18, and 19, and then a decrease of 6.3% in FY20 and an increase of 12.7% in FY21. This reflects what I was speaking about earlier with respect to lower medical utilization in FY20 as a result of the pandemic, and then a rebound in FY21 as people began getting medical care again. We are implementing a significant restructuring of how we charge for our services. We've been in the process of rolling this out for the last couple of months, and it will continue through group renewals this year. This slide shows that price change. Previous pricing was a $1 access fee per month and 2.8% retainage with a cap. The access fee was $1 per employee on your plan. That's pretty straightforward. That fee will go up to $8. Retainage is our term for the share of claims savings. If you save $1,000 on a claim, under the previous pricing, 2.8% or $28 would come to the Alliance. Under the new pricing, that will decrease to 1.9%. Under the previous pricing, there was a cap on retainage, which was originally intended to help out a company that had a quote-unquote bad year. What we found is that most of the employers who qualified for the cap qualified every year, which really was not the original intent. So why are we making this change? Under our old pricing, our revenue is driven by how much we save our members through our contracts. So higher savings results in higher revenue to the Alliance. Many view this as reasonable, thinking if the Alliance saves us money, then it makes sense that they should get a share, and at 2.8%, that's pretty reasonable. However, the other thing that impacts our revenue in this pricing structure is utilization. Obviously, if there's higher utilization, higher use of healthcare services, then it means more revenue to the Alliance. And likewise, if there's lower utilization, there's less revenue. So here's the thing. Many of our strategies that we are making significant investments in and are recommending can lead to lower costs for our members. Our focus is on driving down costs, but by doing so, it can result in the Alliance losing money. In essence, we're spending more as a cooperative to help employers reduce costs, but by doing so, it reduces our revenue. And so this is obviously not a sustainable business model. This was the primary reason for restructuring our pricing. The last thing I'll say about it is that we went through a diligent process to arrive at the new pricing. We involved a subgroup of our board of directors over several months and considered many factors, including market assessments and financial modeling. The subgroup ultimately brought a recommendation to our board, who approved it earlier this year. The new pricing will be rolled out with each group's renewal. I believe all brokers and members have received information about this pricing. So in summary, that's all I have really for prepared slides. Summary is we had a good year financially. We will share in that, and you will be receiving a patronage check. We are in a strong financial position. Our balance sheet is in good shape, and we continue to bring value to our members. And before I wrap things up, I want to give a big shout out to our employees, our members, and our other business partners who are so important to our success. During this pandemic, we have learned to meet your needs in new ways, and I'm talking mostly about working in a remote environment. It hasn't been easy, hasn't always been smooth. The patience and really the pure smarts to get it done has been remarkable. So a big thank you to you all, especially to our members and to our employees. Thank you for your membership in the Alliance, and thank you for being with us today at this meeting. That's all I have for my financial report. Let's see, any costs, or I'm sorry, any questions? I see one coming in. It says 2-year cost trend in PMPM is 5%, 5.6%. Not certain what that means. What it means is that the costs on a per employee basis went up 5.6%. What we're able to do is to break that down. If maybe the question is what does that consist of? We break that down between increases in utilization versus increase in price. So what we know is that increase is a multiplication of number of units you use and the price that you pay. And what we see is about 75% of that increase has to do with medical utilization. And the other part has to do with what we're paying per unit, which we can more directly affect through our contracts. It's the other strategies that we are implementing and that we need your help in implementing that will control the medical utilization side of things. By that, I mean the things that you can do, for example, with your medical, with your benefit design and encouraging proper utilization of health services. I think too, the other thing to observe is that medical trend overall for employers is much higher than what we have seen in our membership over the last decade. Are there any other questions or comments? I'm not seeing any, so if Cheryl, you want to take it over, please do so.
Yes, thank you. I want to start by adding to the comments that Diana Clark made about Wendy Culver. Wendy will be leaving the board, as Diana noted, and I just want to add my thanks, Wendy, to you for your leadership and your support of the Alliance and of me personally. It's just been delightful to work with you. And I also want to note that Paul Meyer is retiring next June after 25 years at the Alliance. And Paul, I just want to say, you know, this was your last treasurer's report, and it has been a joy and a pleasure to work with you. And you have been a wonderful leader and mentor for the Alliance. And we have you until June, so there's plenty of time to say more nice things and tell stories, and there are a lot after 20 years. But it just seemed fitting at our annual meeting to start the tribute. It also, honestly, gives me an opportunity to give you all a heads up that we're going to be recruiting for Paul's position. So if that will start soon. So if you know anyone who you think would be an excellent Vice President of Finance and Operations for the Alliance, send them my way. So it has been a challenging year and a half or so, and notwithstanding the challenges that we have faced, I feel very optimistic about the future, and we have a lot to be grateful for. And what I want to do is spend just a few minutes sharing some of the reasons why I feel so optimistic. The first has to do with the progress that we're making on healthcare transparency. The curtain is going up. You heard Suzanne talk about the healthcare hospital price transparency rules and the health plan transparency rules that will be coming, that began with the Trump administration and are continuing forward in the Biden administration. You'll hear more about this on October 14th at our health policy webinar. But even though we have a long way to go here, hospitals and health plans will fight this likely. But I think the genie is out of the bottle. The toothpaste is out of the tube. The train has left the station. Pick your analogy. This is going to happen. And the days of employers and employees flying blind when it comes to making healthcare decisions are coming to an end. And even without regulation, we have self-funded employers taking matters into their own hands. You've heard a couple times today about the RAND Hospital Price Transparency Study. This effort is one way that employers have started to make progress on their own, absent federal regulations. We saw, as Kyle shared, that the commercial market is paying 250, sometimes 300% of Medicare. And in Wisconsin and Illinois, our prices are high. This kind of unexplained variation really signals an opportunity for waste reduction and improvement, and we are seizing on that. As Kyle mentioned also, quality information is more of a challenge, but I am optimistic that this will also, our use of price will push faster progress on the quality side as well. We will hear from providers, well, you're just buying on cost. You should be looking at quality. To which we will say, yes, we want to do that. What information can you share with us? I think it will be, use of information will help catalyze faster progress. And another reason for my optimism is the boldness that I'm seeing among employers. We have employers who are doing incredible work to make good use of information that's available today on price and on quality where it exists, to create incentives or to make it easy for employees to go where care is good and costs are lower. And this is really an exercise in not letting the perfect be the enemy of the good and making the best use of currently available information. This is exactly what needs to happen in order to drive change in the market. And as employers increasingly adopt this strategy, we will see change occur. In fact, it already is. Another reason for my optimism is that we are seeing a growing number of innovative providers. These are providers who are stepping up to the plate to work with employers, providing different ways to deliver care, a better outcome, better patient experience, and a lower price, often with a warranty. And this is coming as a result of and in expectation of further shifts in market share to these innovative providers. That's where we come in. To name a few names, I'm talking about Novo Health, Ortho Illinois, Twin City Orthopedics, Value Health, and Gunderson Health System. They're counting on us to send business their way when they're delivering better care at a lower price. We're also making inroads by connecting with lawmakers in new ways. Over the course of the last year, we've had a number of conversations with our elected officials at the state level and federal level, and we're getting a warm reception. They want to hear from the employers who are their constituents, who are in their districts. And frankly, they need to hear your voice. They're hearing the voice of those in the industry who benefit from the status quo loud and clear. They really need to hear what employers have to say about the current healthcare climate and how high prices in healthcare are impacting both your business and your employees. Over the course of the next year or so, we're going to be holding meetings around our service area, throughout our service area, hosted by Alliance members with their elected officials, so that lawmakers can hear firsthand what's happening on the ground in their districts. If you're interested in hosting one of those meetings or in participating in one that's in your region, please let us know. We'd love to work with you on that. Another reason why I'm so excited about the future is the news that we recently shared about a sister coalition to the Alliance, the North Central Employers Healthcare Alliance, located in the Wausau market, making the decision to join forces under the umbrella of the Alliance. NEHA, as it's called, was formed in 1997 and really is a kindred spirit to the Alliance. We share so much in common in terms of our mission, our values, our strategies, and our service area. And so we are excited to begin welcoming employers who were part of NEHA into the Alliance beginning January 1st of 2022. And I want to just stop for a moment and welcome you all, tell you how excited we are. I know many of you have joined us on the webinar today, how excited we are to have you join the Alliance and are looking forward to the things that we'll be able to accomplish together. I also want to say a special thanks to Mike Tomczak, who has been the board chair of NEHA for a long time and was one of the founders of NEHA. He's with Colby and Colby Windows. He has a day job, a real live day job, but yet has spent so much time on the care and feeding of this coalition and has been working with us on this transition over the course of the last month. Thanks, Mike. We have so much respect for the work that you've done. I also want to just give a shout out to the third-party administrators who are really simplifying and easing the transition of NEHA employers into the Alliance. So UMR, Auxient, Prairie States, thank you for the work that you're doing on behalf of those employers as well. Lastly, I want to thank the Alliance staff. This is another reason for my optimism. It is a joy to work with a bright and talented staff who are so committed to the mission of the Alliance and to the members that we serve. And really, each of you make the work that we do possible. It's important. We're committed to this, and I want to thank you all for the work that you do every day. And lastly, I want to thank you. Thank you for joining us today. You will be getting a post-event survey in your email inbox, and we invite you to share your thoughts about the content and the process of this meeting. You can also find in that email how to apply for CE credits if that's of interest to you. One final reminder about our next webinar on October 14th, where you'll get an update on some important health policy matters from John Barlament. In the meantime, please reach out if you have questions or comments. We love hearing from you. Have a good day, everyone.